Um, in Mr. Ramkumar's case, just a small factual correction. I'm a member of the broadband, the Indian broadband statistics. We have out of the, Mr. Bedi mentioned about 850 connections, about only for 39 or 40 or the landline. The broadband is only 20 or so, and you cannot categorize mobile as a broadband yet. 2G is not broadband by your definition of 256. So while therefore the numbers from what you said, that number doesn't qualify for so-called 80%. They all qualify for only 50% category. But the good news is during the 12th plan period, the target is about 250 broadband target. So therefore, I think it will move on. The scenario is going to improve only for the better.
So hopefully we have a broadband as the basic right of the people enshrined in our constitution.
See, so far broadband has been anything, 150, 128, anything. But at least TRAI has referred to broadband as 256 for the moment.
Yeah, so what I intended to say was the threshold of 250 kbps in terms of what kind of activities can be done if you give that bandwidth. Correct. I think that is a very critical threshold because it addresses significant amount of transactions. Exactly. So whether it can be provided by 2G or 3G or by a satellite or by DSL.
That. I went through your slide carefully. Yeah. There's a list of things you can do. No, 1 minute, I have not finished. Okay, so that logically I can finish and hand over the baton to him. So that is one important thing. And second is, I think the last speaker was mentioning about many aspects of his talk. One of the thing is, I thought the national movement is, we are doing too much of out-of-pocket expenses, 78.4. So you can't go on and on about business model, how to take more and more money from the people, but also look at, to some extent, some of these payment through insurance, for which employer and government pays for it, but the model is good. Delivery is all perfectly fine through ICT intervention, health worker, all perfectly fine. But the money for that comes from some form of insurance scheme. We can link any of those Bharatiya Bima Yojana. Andhra Pradesh was the first one to do so. So I think many of the ideas are good, but the actual expenditure has come from one of the insurance schemes, I would think so, rather than go on and asking everybody to pay for himself. Because as it is, going to pay for the drugs also. So why do you want to people? So that's the way I feel.
No, I can just correct, give some viewpoints for the, it's on. The viewpoints is in the out-of-pocket expenditure, the 78% what we have, which has been done. Is it for only outpatient or even it's for the inpatient also? Across the board, right? And the out-of-patient expenditure, as I said, the 70% of the cost is into transportation and loss of wages, which is normally is a huge cost. It's not included. 78.4 does not include transportation. Okay, fine. The other case scenario is that even if you have 80% of the outpatient money being spent, the quality of healthcare is not there. So that's what we are trying to. So if you reduce your 80% to say 20%, you pay not 80%, you pay 20% of that 80%. And if you have better healthcare, I think people would be ready to do that. Now the problem is that the RSBY coverage, which is gaining momentum to get the not only secondary care covered but also outpatient covered. We have to see how the government takes up in terms of policies to cover the outpatient and also brings in network for treatments. Now, even if the government covers outpatient, where is the network? So those are the essential things which should be looked
at. Responding to the yesterday's insurance session we had, right now the people from insurance sector, they were mentioning their all insurance companies are health insurance are going in loss, and the one which was doing best was they are getting 95 90 around percent and the other thing the remaining portion was not able to meet the I mean this is again an issue which we may have to consider whether health insurance, unless they increase the premiums, perhaps covering.
So nevertheless, health insurance is the way forward. Though the preferred provider networks and the insurance company needs to set their house in order and to work out the things. And move on to the next question, sir. We're waiting for a long time. After that, we'll pass on to you, Dr. Gogia.
Well, I think this is ICT era, we can call it, for emerging era for ICT. And Madam has pointed out some preventive measures. I think there should be a dedicated channel, national channel, for ICT projections and promotions of the ideas, and that will correct the half of the problem of medicine as such. You will prevent a lot of loss of productivity hours, as Professor has pointed out. That will be contribute to national earnings in return, and really spending will become an easier option for any nation to infuse more money. The productivity of any country is the backbone of economy, isn't it? And I think that if ICT dedicated channel is launched by the government, instead of the programs we come across on the channels, I think there should be some option, rather not option, rather compulsion of launching ICT channel, national channel, which will deliberate on all the diseases and especially the preventive aspect of it. And you can, because this is the age of communications. And television is even in the lowest rung people, they have got the television, whether black and white or color.
Point well taken.
And I think if this is opted, and I think it will make a lot of difference than other.
See, first of all, I think we don't exactly understand what is ICT, but I will like to inform the audience here. See, from National Knowledge Commission, I was part of the deliberation there where we had advocated setting up a national health portal in a very big way with contents relating to all kinds of things which is accessible by anything which can have internet access. So that program already has been approved, and the first level of approvals have gone. It's a very big, 200 crore kind of money which is being spent on this national health channel. And once that comes, I think people can, if they want, to access on any morbidity, any disease or any information, it should be available there.
This will be a major step, sir. And I request Dr. Gogia to put his question, sir.
It is not a question. It was basically the comment that was taking place on the insurance and how, and he had made a very valid point that finally what we are saving through telemedicine is the cost of transport. And that is, in fact, what we have always said, that telemedicine is medicine with tele as a enabler because of certain things which are not possible because of the physical absence of the doctor. And it will always be inferior to physical medicine. So that is one thing which, so how do we compensate for that? And as I had stated in my talk, the patients want it because, as Professor Maurice said, if there is no doctor, he will accept anything that is available, whether it is virtual or, even sitting inside the, in a closed walls, and he says, okay, you just, I'll just feel your pulse and I can give you medicine. Even that is what is done out there. But coming to the insurance aspect for it, and this is what Mr. Girish Babu nicely pointed out. In India, insurance is faulty. Let's put it as simple as that. It is making a loss, we all know. Why is it making a loss? Because they are insisting that unless you get admitted, you will not be reimbursed. It is sickness insurance, as Professor Lele has always said. We need wellness insurance. We need an incentive for the people that if you remain well, you will earn money, I will earn money. If you fall sick, you are also losing money. See, the people tend to fall sick just to say that, oh, I have spent so much money on insurance for such a long time, I should get something back from it. And that incentive has to be removed.
So certainly we hope to see an era where my insurance company is reimbursing my gymnasium bill and my maybe
so,
my
no, not that way.
No, that is a positive point. I mean, if you pay for your subscription.
I was building up a little too much. I'll come to exactly the point I want to say, that we do not have a policy of reimbursing telemedicine.
Yes, we need to move towards the regime. In the previous session, we also discussed that the healthcare may be passed on to the healthcare workers in domiciliary settings. But along with that, we need to add on to make the reimbursement companies to pay for those kind of health treatments also. Unless the insurance companies are not recognizing to pay a domiciliary treatment or the healthcare worker, the things will not move forward. So there are two more hands. Divya, how much time we have?
Yeah.
Maybe a quick question, just a pointed question, and Dr.
Yeah, I just want to make,
okay.
I'd just like to make one comment, just as a follow-up to Sir here. There is, so we work with American insurers, and there the situation is quite bad, actually, right? Because the costs are so high. And because of that, they've been forced to actually start to look at, okay, how do we make insurance an incentive for people? So what they're now looking at doing, which maybe India is a little early for, is something called value-based design, where if someone is healthy and they go to the gym, they eat correctly, so on and so forth, their insurance premiums are lower than if somebody who's not healthy or is not taking, doing things that they are supposed to be doing. So for example, a 26-year-old goes for a colonoscopy, he should be paying a higher rate and be also paying a fine for taking somebody else's place. So, the system, I think, is there, but in India, till they start to cover primary care, which is important, which they don't do today, and as Dr. pointed out correctly, it's mainly sickness. It's not an incentive for people, and they want something, back in return after a point of time. So they're not looking at insurance as, in case something bad happens, I can get covered. They're looking at it as, okay, how do I put it under my ATC, or how do I put it under, which is the wrong. So I think it's an education that also still needs to be done.
So I think what you are pointing at is education and maybe incentivizing the insurance company, rewarding pay for performance kind of models. Those will be equally applicable for us. And Dr. Morris Mars, what are your views?
Yeah, in fact, thank you. There is a term that I haven't heard it mentioned all day, and I'm hoping it's not being mentioned because it's being done. All of us accept that ICTs in health are the right way to go. If we all accept it, and it is so obvious, in fact, why isn't it being adopted? Internationally, the trend is to move towards understanding what the human factors are that are impeding the uptake of ICTs in health. So change management. So if you go and read up about change management, one is supposed to budget at least half again of your total project costs for change management. And that's something that I don't see happening. And the extreme of change management is to make the people in the villages and the communities so aware of the benefits that they demand it. They vote. And if they demand and they're not getting, their vote may go somewhere else.
It's a very valid question. What issue he is raised is if ICT is such an enabler and differentiator, why it is not being adopted at a larger scale? Let me try to answer that question. Firstly, there are several reasons. There's no one reason why is it not adopted. Let's start with it's a capital intensive proposition. You need a good amount of sum to install a EMR or a few applications which are being demonstrated downstairs for telehealth cost minimum 15 lakhs. And of course, he's brought out that there are cheaper solutions also with the basic infrastructure available. We can still deliver telehealth. Second issue is that there's a kind of cultural barrier. Technology is available, but still somehow I feel Indian doctors, they feel more comfortable sitting across the patient. Patient wants physical touch. And so that is part of a doctor-patient relationship. Third thing is it doesn't offer you like installing EMRs in a hospital. It doesn't allow you to experiment with EMRs. There's very little experimentability, and once they are there, you have to accept them or the whole project goes in for flop. A fourth issue could be that doctors by their own value are quite autonomous. They want independence in their decision making. They do not want to be guided by set protocols or cookbook recipes. So there are a lot of issues, mainly cultural barriers in adoption of IT, and then minor irritants issues and challenges like medical legal issues, translation issues, which have been enumerated by panelists. So overall, there's no one single reason. But there's no need to feel to get deterred or discouraged. Also,